Let's jump right in. For any nurse, those first 10 minutes with a new patient, they can literally change everything. It's a huge responsibility. But what if the way we think about that initial assessment is just wrong? Today, we're going to flip the script and reframe it, not as just another task, but as the critical, life-saving skill it truly is.
First things first, let's get one thing crystal clear. That admission form, that list of boxes you have to tick, this is not paperwork. If you see it that way, you're missing the entire point. And honestly, you could be putting your patient at risk. We've got to kill that mindset.
So if it's not paperwork, what is it? Well, what you're really doing is clinical surveillance in its purest form. This is your professional judgment, your clinical mind being put to work in a structured, systematic way. Think of it like this. You're a detective, and this is your high-stakes investigation to protect your patient.
So, let's move beyond just thinking of this as a checklist. We're going to dig into the why. The real reason this process is the foundation of patient safety. The official definition really says it all. The initial assessment is a systematic valuation. It has three main goals. First, find anything that could be an immediate threat to life. Second, figure out what this patient's normal looks like, their baseline. And third, and this is crucial, to catch the very earliest, most subtle signs that something is starting to go wrong. So how do we actually pull this off, especially when things are hectic? Well, there's a gold standard method used all over the world, the primary survey, which you probably know as the ABCDE framework. This is our roadmap. We're going to break this 5-step scan down piece by piece. And trust me, following this sequence isn't just about best practice. It makes sure you tackle the most life-threatening problems first, every single time. And it all starts with A for airway. This is the one thing that is absolutely non-negotiable. If your patient can't get air in and out, nothing else you do is going to matter. It is always, always priority number one. So how do we check it fast? Simple. Ask them a question. Can they speak a full sentence back to you? That tells you so much. From there, you're listening for any signs of blockage, and you're checking to see if they need any support or if the oxygen they're on is set up right. And this quote just nails it. A problem with the airway is an emergency. You have to act right now. You intervene first, you document later. Airway always, and I mean always, comes before paperwork. Okay, once you know that airway is open and clear, you move straight to B for breathing. Are they actually moving air effectively? Is their body getting enough oxygen? This is all about the mechanics of breathing. So you're looking at their respiratory rate, the rhythm, how deep the breaths are. Are they using extra muscles just to breathe? That's what we mean by work of breathing. Then a quick listen to their lungs and a check of their O2 sat gives you the rest of the picture. Now, this right here is a golden rule in nursing. That's slightly fast breathing, what we call subtle tachypnea. That is so often the very first sign that your patient is starting to get into trouble. It's like a quiet alarm bell that this structured assessment helps you hear loud and clear. All right, airway is good, breathing is good. Now our focus shifts to C for circulation. Is the blood actually getting to all the important places? We're checking out how well the whole cardiovascular system is doing its job. So you're feeling for that pulse. Is it weak and thready, or is it strong? You're checking blood pressure, looking at their capillary refill, feeling their skin to see if it's warm and dry or cold and clammy. Every single one of these is a clue. And here's where you put those clues together. This is the magic of clinical reasoning. When you see low blood pressure paired with a fast heart rate, your brain, guided by this framework, should immediately be thinking, this could be shock. You're turning data points into a potential life-saving diagnosis. Okay, moving on to D. D stands for disability, which is really just our quick and dirty neurological assessment. How's the patient's brain doing? Is it getting enough oxygen and blood flow? A super fast way to do this is with the AVPU scale. Is the patient alert, or do they only respond to your voice, or to pain, or are they completely unresponsive? You'll also check their orientation and pain score. A sudden change here could be a really early sign of a big problem. And finally, we get to E for exposure. This just means we need to physically see what's going on with the patient's body, because clothes can hide a lot of really important clues. So this is where you're checking their temperature, you're doing a full body scan looking for rashes, checking their skin, looking for any hidden bleeding or bruises. But, and this is a big but, you have to do all of this while carefully, respectfully, maintaining your patient's dignity. That part is non-negotiable.
Okay, theory is one thing, but let's see how this actually works to prevent a disaster in a real-world situation. Let's put all this into practice.
So, a patient gets to your floor from the ER. Here's what you see. Respiratory rate is 26, their O2 sat is 92%, they're alert but seem pretty anxious, blood pressure's fine, and you hear some mild crackles in their lungs. Now, at a quick glance, you might think, okay, not great, but maybe not an emergency. But this slide shows the whole point. A random glance might see a patient who just seems a little off, but when you use the ABCDE assessment, you see the full story. The fast breathing, the borderline oxygen, the anxiety, the crackles, you put it all together and what do you have? You have early respiratory compromise. This patient needs help now, not in an hour.
And you know, this amazing tool isn't just about what you do as an individual. When a whole team gets on board with this, it builds a foundation for incredible care and a powerful culture of safety. This assessment is leadership in action.
Just look at what the best nursing teams do. They all use the same standardized language so there's no confusion. Their documentation is precise and tells a clear story. They use early warning scores based on this data. And maybe most importantly, they call for help based on clear signs, not because they're afraid of being wrong. And it all starts with that solid, structured assessment.
So let's end on this powerful idea. Your initial assessment isn't just another item on your to-do list. It is your diagnostic brain in action. Never forget, you are not just a task performer. You are a frontline clinical decision maker, and this systematic assessment is one of the most powerful tools you have to save lives.